Good morning, all. We are about to begin our session on Diplopia Demystified. So I thank KSOS Scientific Committee for giving me this opportunity. And I welcome Dr. Amrita Sindhu, who is with us to give a keynote address, and all the co-speakers and all the delegates here. Speaker will be Dr. Amrita Sindhu. She's a consultant pediatric ophthalmologist and pediatric neuro-ophthalmologist working at Arvind Eye Hospital, Coimbatore. Over to you, madam.
Thank you, Dr. Rekha. A very good morning to everyone. So at this outset, I would like to thank KSOS Drishti team, Dr. Rekha, Suma madam, for this opportunity. I'm really glad to be here. So I'll be talking about interventional management of diplopia and when and how to do it. So it'll be more of a practical session rather than a theoretical session. So there are various sites of lesions which can cause diplopia. So I think the subsequent speakers will be talking about this more in detail. So it can be a supranuclear lesion, nuclear, infranuclear lesion, or it can be an orbital lesion or a myasthenia gravis, which can all cause diplopia. So for the convenience of my talk, I have divided my talk into three groups, that is diplopia caused due to neurological disorders, diplopia due to ocular disorders, and diplopia due to binocular vision anomalies. Among all this, I'll be talking about both non-surgical intervention as well as the surgical intervention. So before proceeding into diplopia proper, one thing you should always make sure is always rule out a monoocular diplopia. Many a time patient will come to your clinic, so you will be thinking of various causes of diplopia. One simple question before starting evaluation of diplopia is, does the diplopia persist when you close one eye? So if the patient says yes, then the management part will completely change. So it can be some ocular causes like a refractive error, corneal lesion, or a retinal pathology. So always make sure it is a binocular diplopia before proceeding. So one more common thing which you see in clinic is patients may not clearly say it is diplopia. They will say that I have a blurred vision, I have difficulty walking. So it is more of a confusion than diplopia. The confusion means the patient is seeing two images at a time and he's confused which is right, which is wrong. So in that case, first what you have to do is you should make him diplopia aware. So you just show him where the second image is and you make him diplopia aware, then your evaluation will become more easier. So now I'll first take up the non-surgical management of diplopia. Among that, I think the prism plays a very vital role. So I'll be talking about prisms now. So as you all know, the prisms, they alter the path of light and helps to align the image over the fovea. So we decide on the appropriate prism which can make the light rays to fall on the fovea. So mainly two types of prisms are used. They are ground-in prisms, otherwise called as glass prisms, or stuck-on or Fresnel prisms. So the indication for prisms are, mainly the cranial nerve palsy. When you're waiting for a spontaneous resolution, patient is having a troublesome diplopia. To alleviate the diplopia, you can use these prisms. It can be a decompensated strabismus, any thyroid orbitopathies, skew deviations, and post-ocular surgeries if patient is complaining of diplopia. For example, post-cataract surgery, if there is a, due to your bridal suture, if you have a superior rectus damage, that can cause diplopia. So, or a retinal surgery such as using buckles or any alteration in the retinal anatomy can also cause diplopia. These can be managed with prisms. Moving on to ground-in prisms, up to 8 to 10 prism diopters can be ground into lenses. So the idea is to split the power between either eyes, so you can split it. Usually these ground lenses are very well tolerated because the clarity of the image is not disturbed. So, but only drawback is it will look little heavier, the glasses look little thicker, so as compared to the Fresnel prisms. So I would like to give an example of a patient who presented with a thyroid orbitopathy recently to the clinic. You can see there is a lot of signs of ophthalmopathy. Right eye is hypotropic because of the IR involvement, and there is an elevation limitation in the right eye. So here is a small video which can show you how you can decide on the appropriate prism. So first I'm using a red filter to make the patient aware of diplopia so that he can identify where exactly the second image is. Then I'll start using the prisms and start neutralizing the deviation first. Once I neutralize the deviation, I'll ask the patient how the images are. So he can say that the images have come closer with one particular prism. So you go on increasing or decreasing the prism until the patient can fuse both the images. So here the patient is fusing with 16 prism diopters of prism. So the next thing what I do is I use these prism lenses which can be mounted on a trial frame. So you can put those. I'm splitting the prism between either eyes. So one is base down and base up. So you can use those and alter the strength of the prism as until the patient fuses. So you always keep in mind whenever you're neutralizing a vertical prisms, usually the patient doesn't have a large fusional amplitude. So you have to almost correct the entire value. Whereas in horizontal prism, even by 50% of neutralization of value, patients can fuse. So deciding on whichever prism is comfortable, you can decide on the values of prism. Moving on to Fresnel prism, it's a thin row of prisms which appears like a sheet. So you can compare in this picture the conventional prism and a Fresnel prism. The thickness is so much variable. So it just appears like a thin sheet where a row of prisms are mounted. So the advantage is it is very lightweighted, cosmetically very acceptable, and you can give up to 30 prism diopters of Fresnel prisms. So this is how you get a Fresnel prism. Usually it will come as a sheet. You can have this trial lenses. Even Fresnel is available as trial lenses. You can just use it with your the spectacle thing, and you can see whichever Fresnel prism is comfortable for the patient. So and then you can order that Fresnel prisms. So again, prescribing this oblique prism is little bit difficult. So as you try on during your routine practice, you get used to it. So basically when you're prescribing an oblique prism, so you just neutralize the deviation both horizontally as well as vertically using your prisms. Then this chart is available, which is called Reinecke's chart. So here using this vertical deviation prisms and the horizontal deviation, you can decide on the vector prism which is required. So this chart gives the idea. So like 15 prism diopters at 6 degrees. So you can read the value from this chart, and either you can pre-order this directly from the company, or you can use this compass which is available. There's a beautiful article by Reinecke et al. Which is available in Archive Ophthalmology. So this gives a complete idea of how to prescribe the oblique prisms. You can use this compass. You can just place the Fresnel prism on this compass, mark the axis, and you can cut it according to the shape of the patient's spectacles, and you can just stick it over the surface of the spectacles. So the drawback of Fresnel prism is it alters the visual acuity, because especially when you give it more than 12 prism diopters, it can reduce the vision. So patient can have some glare, optical aberrations. That is the only drawback. So moving on to the next non-surgical intervention is the botulinum toxin, which when properly used, it's really a boon. So usually the commercially available commonly used preparation is the Botox. So it is a sterile vacuum dried crystalline form of drug which is available in 100 unit toxin. In smaller practice, you can just pull up all your cases together, call on one day, and you can use it. Usually the onset of action is 1 week, and the peak effect is seen by 3 weeks, and the duration of effect lasts for 3 to 6 months. So indication, there are various indications in ophthalmology, but for the diplopia part, it is mainly used in cranial nerve palsies, especially in all this when patient is having a very troublesome diplopia, not able to do his routine work, you can give this option of giving a botulinum toxin, which helps in a faster recovery. You can also use this in acute comitant esotropia, which is called as ACE nowadays, which we are commonly seeing in our routine OPDs. And also there is a thought of using it in infantile esotropias, where giving an early botulinum toxin can cause cranial rewiring, and the infantile esotropia can completely resolve without recurrence. So these are the few commercially available preparation. The commonly used one is the Botox. So when to use is really important. So botulinum toxin is effective when you use it within 1 month of onset of diplopia. So that is because after 1 month, usually the antagonistic muscle will develop some amount of contracture. So you may not get the full effect of botulinum toxin. So always plan to give injection within 1 month of onset of symptoms. So this is a video showing how to reconstitute the botulinum toxin. So usually you will get it in a freeze-dried powdered form along with the diluent or the normal saline. So what you have to do is you just withdraw the desired amount of sodium chloride, the saline, and then it is injected into the drug. So since it is vacuum preserved, you just have to prick it, the saline just goes in directly. And you just give a gentle rotation. Don't vigorously shake the bottle because that can damage the effectivity of the drug. So withdraw the desired amount of drug to be injected, and then the rest of the drug goes into the refrigerator, which can be used within 48 to 72 hours of reconstitution. So this dilution table is important. If you dilute with 1 ml of normal saline, you will get a strength of 10 units per 0.1 ml. So accordingly, you can decide about the strength which you want to give the botulinum toxin, and you can give it to them. So this is a small video showing the procedure how to give botulinum toxin for an extraocular muscle. So the muscle, first identify the muscle, hold it with the forceps. So directly inject the needle completely into the muscle. Make sure the needle is completely in the belly of the muscle. Then inject the drug and gently withdraw and give a gentle pressure so that you can prevent extravasation of drug. Most of the complications of the botulinum toxin happens because of the extravasation of the drug. So giving it subconjunctivally is really helpful because it can prevent this complications. So all the complications are very transient. Within it exists for around 2 to 3 weeks. So the common complication is ptosis, and sometimes they can have diplopias. So hematomas at the site of the injection are the common complications which you see. So this is a small child who presented with the 6-nerve palsy in the left eye following an episode of fever. Imaging was done, which was normal. So we waited for like 2 to 3 weeks. There was no resolution at all. Child was having a severe abnormal head posture, and in order to prevent development of amblyopia, we gave an option of botulinum toxin to the patient. So they accepted. This is 2 weeks post injection. You can see there is complete recovery of esotropia, although there is a subtle ptosis which will usually resolve within another 2 weeks. So moving on to diplopia, management of diplopia due to binocular vision anomalies. Although you will see a lot of cases of these binocular vision anomalies, the most common ones is the convergence insufficiency, which patient usually complains of diplopia on prolonged reading while using near works more. So mainly the management wise, you can give office-based Vergence therapies or home-based Vergence therapies. Commonly used ones are Brock strings really works well. You can use fusion cards such as dot card, cat card, eccentric circles. There are also a lot of commercially available software exercises which can be used provided the patient has a facility of internet and laptop at home. Of course, you can, if these doesn't work, this is the first line of treatment. If this doesn't work, then you can go for a base in prisms, which can help to alleviate the symptoms. And surgery, although is there, but it is not really done often because most of the time all these Vergence exercises really works well in convergence insufficiencies. One more common thing which was coming up of late, we are seeing more of these divergence insufficiency cases. So patients who are presenting with acute ET, which is more for distance as compared to near, or complaining of diplopia only while looking at distance, think of divergence insufficiency. So divergence insufficiency, we don't know exactly what is the cause. So majority of the time, it is just this esotropia alone, which is a comitant esotropia without any limitation of extraocular movements, you don't have to really image all the patients. Only if they have any neurological signs, you can think of imaging, because some of the cranial lesions can also present with similar complaint. If it is only this ET presenting only for distance, sometimes just a spontaneous resolution can happen. All you have to do, give them is some divergence exercises. Brock string exercises, when it is done in a reverse direction, it gives a divergence exercises. So you can use that. Usually patients' symptoms will resolve. Or you can try giving them base out prism. So orthoptic exercise is the first line here again. So if that doesn't work, then if the patient continues to have this esotropia for quite some time, then you can decide on surgery. The best surgery to do in these patients is just go and do a simple lateral rectus plication. So that can work really well for this divergence insufficiencies. Moving on to surgical management. So I'll not go into details of each surgical management. So I'll just be giving few indications and the techniques which are used. So any cranial nerve palsy, as you all know, we will wait for the first 6 months, especially if it is because of any diabetic or mainly the ischemic neuropathies. So you wait for spontaneous recovery for 6 months. If there is no resolution, then you can plan for a surgery. Any acute comitant esotropia, also called as ACE. So you don't have to really wait for 6 months. 3 to 4 months of constant deviation, you can plan for a surgical correction. Or suppose you have given botulinum toxin, again patient had a recurrence of squinting nerve palsies, then you can go for a surgery. So especially patients presenting with diplopia, it's always better to put them on adjustable sutures, because you want to get the right amount of correction so that the patient will be diplopia free. So the common indications for adjustable suture is this thyroid ophthalmopathies, acute comitant esotropias, any decompensated strabismus or partially recovered 6 nerve palsies, you can decide on adjustable suture. So before planning for surgery, it is very important to check the fusional potential. So try prisms, identify which prism is a patient is able to fuse. Based on that prism value, you decide your surgeries. So that is the value for which you will be giving the adjustable sutures. So adjustable suture, you can either do it topical or with if it is a cooperative adult patient where you have to just adjust a single muscle, you can just put an adjustable suture on table, make the patient sit, show him a Sneller's chart, and you can see, you can assess the diplopia, and again you can just adjust it on table itself. So suppose you want to plan for an adjustment on the next day, you can either use a bow tie technique of surgery or a sliding noose technique. So 6 nerve palsy, again it depends on the activity of the lateral rectus. If the lateral rectus activity has recovered very well, movements are almost full, only the esotropia is remaining, you can go for a regular recess resect procedure. So suppose the lateral rectus activity has not recovered, lateral rectus is functioning very poorly, then you can plan for a transposition procedure where you are transposing the superior rectus and lateral rectus, inferior rectus towards the lateral rectus. If you split the muscle, you and transpose the entire muscle, then it becomes a Hammershim procedure. You just pull the muscle and suture it to the lateral rectus, it becomes a Nishida's procedure. So 4th nerve palsy, again you decide on surgery based on whether the patient has a torsion or without torsion. So if the patient is not having torsion, it is only the vertical deviation, you can just go for an inferior oblique weakening procedure, or you can combine inferior oblique weakening along with a superior oblique strengthening procedure. So if the patient is complaining of torsion, which you can identify in your clinic by using a double Maddox rod technique, if the patient is having torsion, then it is always better to go for a Harada-Ito procedure. Harada-Ito procedure is nothing but the anterior 1/3 of the superior oblique muscle belly is just separated and it is sutured close to the lateral rectus. So this will strengthen the anterior 1/3 of the fibers alone, which can prevent the torsion. 3rd nerve palsy is most difficult one to manage surgically. Recently, this technique has come up, which is really helpful, which is nothing but you split the lateral rectus entirely up to equator and bring it all from the superior oblique, superior rectus, inferior oblique, inferior rectus, and you suture it near the medial rectus. So this nasal transposition of split lateral rectus really works well in this third nerve palsies. So to conclude my talk, so always it's a combined management of both the neuro-ophthalmologist and the strabismologist. So initial management usually will be taken care by the neuro-ophthalmologist, and later on when there is a management, surgical management required, you can plan for a surgery by strabismologist. So you have to decide on appropriate plan of action right from the time of your diagnosis. So timely decision making is really important when you can do it. So do it at the right time, or you can also give an option of referring the patient. All this timely management and appropriate decision making will help for a successful outcome. Thank you.
Thank you, madam, for that wonderful presentation with beautiful videos. So we'll take the questions at the end of the session. Now, next I welcome Dr. Suma Unnikrishnan. She is Associate Professor at Government Medical College, Mancheri. Over to you, madam.
Good morning, one and all. At the outset, let me thank KSOS and Dr. Rekha for including me in this session. So, diplopia charting is nothing but a recording of the diplopic images in 9 cardinal positions of gaze. It can be done either in a patient's view or examiner's view. In patient's view, the examiner stands behind the patient and plot the chart, project the light to the front wall. In examiner's view, the examiner stand in front of the patient and shine the torch. Both are correct, but you have to mark the chart with the side. For example, in this is a patient view, so the right side will be marked here and the left here. The same chart, if you chart in the examiner's view, the side will be the opposite, the patient's right here and patient's left here. So you have to follow some precautions while charting, and the patient should be asked about the tilting of the images, area of maximum separation using their fingers or red and green pencils. And you have to remember a few points. The diplopia will be more in the field of action of paralyzed muscle, and the image seen by the squinting eye will be the fainter one, and the farthest image is from the affected side, and it can be horizontal, vertical, torsional or combined, and it may be crossed or heteronymous or uncrossed or homonymous. Esotropia always produce uncrossed diplopia and exotropia produce crossed diplopia. Now remember, all recti palsy except lateral rectus produce a crossed diplopia. Lateral rectus palsy as well as oblique palsy produce uncrossed diplopia. Now we can go by step. First, find out in which case there is maximum separation of images. After that, you think of the yoke muscles responsible for that particular gaze as shown in this picture. And now note which is the outermost image, which will be fainter and farthest one, and that is due to from the affected side. Then observe whether it is a crossed image or an uncrossed image. Now let us consider some examples. Here you can see the image separation is maximum in levo version. So which are the yoke muscles for this levo version is left lateral rectus and the right medial rectus. Here, which is the farthest image? It is from the left eye, because you are wearing the goggles with red in front of the right eye. So the left image is the corresponding, the green image corresponds to the left eye. So this is the farthest one. So this is the affected eye. So left eye. And this is this is uncrossed image because red is on the right side. So uncrossed image of the left eye could be due to left esotropia. So this is a left lateral rectus underaction. Okay. So coming to this chart here, this is more separated in the dextro version, but this is a crossed image. So this is green on this side. So which are the yoke muscles? It's the right lateral rectus and the left medial rectus. Okay, so the farthest image is from the left eye. So left eye farthest image, left medial rectus is involved. Okay. Now coming to vertical muscles, it can either the recti or obliques. So if it is uncrossed, it is an oblique palsy. If crossed, it is a recti palsy. Now you think of these mnemonics, that is superiors, that superior rectus and superior obliques. The tilt of the image will be to the sound side. Inferiors will tilting to the ipsilateral side. Now consider these examples. So this here, the maximum separation is in levo elevation. So which are the yoke muscles? Left superior rectus and the right inferior oblique. The farthest image is from the left eye. So we consider left superior rectus. You can confirm that the recti produce a crossed image. So see that the green is towards the right side. Not the tilt is to the, this is superior, no? Superior will tilt to the normal side, sound side. So tilting is to the right side, okay? So this will be a superior rectus under action. Coming to this example, here the maximum separation is in levo depression. So which are the muscles? Left inferior rectus and the right superior oblique. Here the farthest image is from the left eye, so left inferior rectus. You can also confirm that recti produce a crossed image, so the green is towards the right side, okay? So the tilt is towards the ipsilateral side, so the tilt is to the left side. So this is left inferior rectus under action, okay? Now here also, now you consider this one, this here, this is the dextro depression. So right inferior rectus and left superior oblique. The left eye is affected and the left superior oblique, and here obliques are uncrossed. So the red is on the right side. So the superiors will tilt to the sound side. So this is this tilting to the right side. So that confirms it is a left superior oblique under action. Now one more example. Here it is dextro elevation, where it is maximum, the separation. So the left eye is affected. So the muscles affected may be either right superior rectus or left inferior oblique. See it is a crossed image. So this is an uncrossed image. This is an uncrossed image. Right, the red is on towards the right side. So and also here there is a tilt is to the ipsilateral side. So it is a left inferior oblique under action. So consider this one, the all cases shows diplopia except dextroversion. Here it is a crossed image. The farthest is from the right eye. So the right eye crossed image with a normal lateral rectus is right third nerve palsy. Okay. So remember, third nerve palsy produce a crossed diplopia, fourth nerve and sixth nerve palsy produce uncrossed diplopia. You do this when in conditions where in concomitant strabismus, where patient complains of binocular diplopia, not only to confirm diagnosis but also in follow-up of patients to know whether progressing or is it responding to treatment or surgery. But the fallacies are, it is purely subjective and it is unpredictable in uncooperative patients as well as when there is a contracture of the antagonist has developed. So thank you for your patience here.
Thank you, Dr. Suma, for that illustrative talk. I call upon the next speaker, Dr. Sandhya Somasundaram, working as Associate Professor in Kozhikode Medical College. Over to Dr. Sandhya.
Good morning, everyone. First of all, I thank Suma Madam and Dr. Rekha for giving me an opportunity to participate in this IC. Now, first we'll deal with evaluation of a case of diplopia. So basically, whenever, as Dr. Amrita said, whenever a patient complains of diplopia, you have to evaluate whether the patient is having either monoocular or binocular diplopia. How will you ask that in history? Yes. Does diplopia go away by closing either of the eye? Or is it same? That does diplopia go away by closing one of the eye? Is there any difference? Actually, this is correct. Why? Because if a patient is having monocular diplopia and if the affected eye is closed, then also the patient will say that he or she is not having diplopia. So always you have to ask whether the diplopia, or you have to check whether the diplopia go away by closing one of the eye. Either of the eye. So monocular diplopia, the cause is almost always ocular. And other features are usually diplopia goes away with pinhole. And another important point, as I said, is it persists on occlusion of unaffected eye. Then rare exception of this is cerebral polyopia or diplopia, which is visualization of multiple or double images that persist in each eye with monocular closure or pinhole. It is caused by posterior cerebral lesion. So, even though it is monocular, the cause is cerebral. The causes of monocular diplopia are refractive errors, corneal causes, dry eye, cataract, subluxation, large iridodialis, fourier turning to tropia, etc. We'll deal with the example. An 18-year-old female came to her OP with complaints of diplopia, which she noticed for past 1 month. And diplopia disappears when she closes her right eye. So we may think it is a binocular diplopia, but on examination, extraocular movements were full and rest of the anterior and posterior segment examination was within normal limits. And her diplopia charting doesn't look much significant because you can't say which is the most separated point at all. So we did a refraction and you can see the astigmatism in the right eye. And when we prescribed the glasses, her diplopia actually went away. Now, binocular diplopia, the cause is almost always neurological. Again, there is a rare exception where it is reported with a retinal problem in one eye, such as an epiretinal membrane, and due to disruption or dragging of the fovea and macula from their usual location. As a result, a relative misalignment of the fovea and binocular diplopia occurs in the absence of true neurological ocular misalignment. And one clue to this is actually the presence of metamorphopsia with Amsler grid testing. Again, the cause of binocular diplopia is so much, that is supranuclear, nuclear, internuclear, infranuclear, muscular and neuromuscular junction. Today we'll deal with more of supranuclear and nuclear and internuclear causes. The rest will be dealt by the next speaker. Supranuclear causes gaze palsies. The thing is that usually it affects the range of movements symmetrically. So usually visual symptoms like diplopia is usually minimized by the symmetry of the process. The binocular diplopia will occur only when the two eyes are affected differently, just like in INO and 1.5 syndrome, which causes an ocular misalignment. But it is said diplopia may also be more common in gaze palsy when the deficits have an acute onset, such as with infarction. So some of the vertical gaze palsies are upgaze palsy in dorsal midbrain syndrome, progressive supranuclear palsy, and skew deviation. Out of them, skew deviation causes diplopia more because there is a misalignment in skew deviation, and progressive supranuclear palsy rarely causes diplopia. So usually in vertical gaze palsy, if it is an acute onset like in ischemic infarction, you can get diplopia, but usually it occurs along with other symptoms like unsteadiness of gaze or vertigo, and it is more commonly associated with Vergen's anomalies also. Here you can see that the horizontal gaze is normal, but the vertical gaze is affected. Then again, dorsal midbrain syndrome, you all know, it is associated with upgaze palsy, convergence retraction nystagmus, lid retraction, and also light near dissociation. Progressive supranuclear palsy, you get upgaze palsy along with other symptoms of gait disturbances. Then skew deviation. This is important. Why? Because it causes diplopia because of the vertical. One eye goes down when you occlude and the other eye goes up. This is the classical skew deviation. And yes, you can see deviation. This is skew deviation. It occurs in the lesions of supranuclear pathways connecting the vestibular apparatus to the vertical ocular motocranial nerve nuclei, or even in acute vestibular involvement. So vertical diplopia along with head tilt and torsional rotation is called as ocular tilt reaction, and that also should be noticed. How to differentiate skew deviation from superior oblique palsy? So there is a test called as upright supine test to differentiate skew deviation from trochlear nerve palsy. In this, a vertical deviation that decreases by more than 50% from upright to supine position suggests skew deviation and warrants investigation for a lesion in the posterior fossa as a cause of vertical diplopia. This upright supine test becomes positive only for skew deviation. Then horizontal gaze palsy, it includes acadic gaze palsy, smooth pursuit palsy, horizontal gaze palsy, INO and 1.5 syndrome. Among them, INO and 1.5 syndrome most commonly cause diplopia because of the asymmetry. Here you can see a simple horizontal gaze palsy, and this is a case of internuclear ophthalmoplegia. This is due to a lesion of MLF. Here you can see right gaze is normal, and on attempting left gaze you get restriction of adduction of the right eye And in the abducting eye, you get nystagmus. This is the classical INO where you get in MLF lesions. This is 1.5 syndrome. This is due to a lesion of MLF plus PPRF. Here again you can see difficulty to look towards right, and on attempting left gaze again there is adduction restriction in the right eye, and in abducting eye you get nystagmus. Then nuclear and infranuclear causes, look for the evidence. It is obviously evident. There will be evidence of cranial nerve palsies, movement restriction will be there. And if it is a nuclear or vesicular lesions, always look for associated brainstem involvement. And for sixth nerve nuclear lesions, always look for associated seventh nerve involvement. Then orbital causes can also cause diplopia. You have to always rule out thyroid ophthalmopathy, orbital pseudotumor or any other inflammatory pathology, orbital neoplasm, orbital flow fracture with muscle entrapment or myasthenia gravis, and FTT will really help in such situations to rule out restrictive causes of diplopia. Thank you.
I call upon the next speaker, Dr. Rekha, to present a topic on localizing the cause for diplopia, a stepwise approach. She is working as associate professor in Manjeri Medical College.
So good morning all. I'll be talking on localizing the cause of diplopia. So whenever you see a case of diplopia, we have to identify which is the muscle that is involved. The next step will be to identify where is the lesion. So it can be at the supranuclear level to the cranial nucleus, the cranial nerve at various levels, and even at the orbit and at the muscle itself. So we'll see. When a patient comes with abduction deficit, this is a patient with the abduction deficit. So where all can be the lesion. So it can be the most proximal area where an abduction deficit can occur will be at the supranuclear level. So it can be at the frontal eye field. From the frontal eye field, neurons pass on to the contralateral PPRF, from the PPRF to the sixth nerve nucleus. From the sixth nerve nucleus, neurons pass on to the ipsilateral lateral rectus and the contralateral medial rectus through the MLF. So in these areas, that is frontal eye field, PPRF and sixth nerve will usually cause a gaze palsy, and usually there is no diplopia. But as Dr. Sandhya told, if there is any asymmetry, that can also cause a diplopia. Now, nuclear sixth nerve palsy, it causes a ipsilateral horizontal gaze palsy. Along with that, there is associated facial weakness also can occur because of its close association with the facial nerve fibers. Now, fascicle of sixth nerve, from the nucleus, it move on to the important structures like medial lemniscus and corticospinal tract. So, assessment of proprioception and touch, and also look for any contralateral hemiparesis. If this is present along with the sixth nerve palsy, think of the fascicular part. It is also associated with syndromes like Fowley syndrome and Millard-Gopler syndrome. Now, as the sixth nerve leaves the brainstem at the pontomedullary junction, it lies in the CSF space. So here, it can be associated with meningitis. And also, the acoustic neuroma can affect the pontomedullary junction. So these should be considered. Always look for features of meningitis like headache, neck pain, or light and sound sensitivity. Now from here, it ascends along the clivus to enter the cavernous sinus. So here there is a sharp turn towards the to pass to the Dorolus canal. Here it can be affected by the stretch injury in raised ICT, and also petrositis, mastoiditis, and even base of skull fracture can also affect this area. Now from here it enters the cavernous sinus. Cavernous sinus, as you all know, it may be associated with other cranial nerve palsies like 3, 4 and first part of the fifth nerve. And the abducens nerve lies within the cavernous sinus. So it can be associated with the abduction deficit with ipsilateral Horner syndrome because of the sympathetics around the carotid plexus. So abduction deficit with ipsilateral Horner syndrome, you can think of cavernous sinus part. Now from here it enters the orbit through the superior orbital fissure. Here the orbital apex syndrome, that is along with the 346 cranial nerve, the optic nerve also can be affected. So if there is 346 cranial nerve along with RAPD or visual acuity is affected, think of orbital apex syndrome. Now, that was in short about abduction deficit. Now, next a patient coming with adduction deficit. Adduction deficit, which is a muscle involved, that is a medial rectus muscle. It is usually associated with third nerve palsy. So, the most proximal area where adduction deficit can occur will be the internuclear ophthalmoplegia, that is MLF. The MLF damage can result in adduction deficit with contralateral abducting nystagmus. Now, nuclear third nerve palsy, it is usually, there are certain specific features to tell it is a nuclear third nerve palsy, like bilateral third nerve palsy without ptosis, or it can present as unilateral third nerve palsy with contralateral superior rectus weakness, or it can sometimes present as bilateral partial ptosis also, because it is because of the peculiarity of the nucleus, that is superior rectus subnucleus innervates the contralateral superior rectus, and the LPS subnucleus innervates bilateral LPS muscle. Now, the fascicular third nerve palsy, here from the nucleus it passes through the red nucleus. Red nucleus, when it passes through the red nucleus, any lesion at the level of red nucleus can present with contralateral tremor. So, contralateral tremor with third nerve palsy, think of that is Benedict syndrome. And when it passes through the cerebellar peduncle, it can cause ipsilateral cerebellar ataxia, that is an Nagel syndrome. And it can pass through the cerebral peduncle causing hemiparesis with third nerve palsy, that is a Weber syndrome. Now, the cisternal third nerve palsy. Here, the third nerve is closely associated with posterior communicating artery. So, aneurysms of the posterior communicating artery will affect the third nerve. It usually presents with acute painful third nerve palsy. So, any case presenting as acute painful third nerve palsy, think of the cisternal part of the third nerve, and it usually presents as isolated third nerve palsies. Now, the pupillary fibers, the third nerve palsy can be a pupil sparing or pupil involving. The pupillary fibers are present in the superficial part of the third nerve. So, aneurysms and tumor usually involve the pupil, and conditions like diabetes and hypertension usually presents with as pupil sparing third nerve palsies. Now, next, the cavernous sinus, as we just discussed, is causes of multiple cranial nerve palsy, and the orbital part, one thing to remember, it divides into superior inferior division. The superior division usually supplies the superior rectus and LPS, and inferior division the other muscles. Now, a few words about elevation depression deficit. One is supraadduction deficit, that is elevation. It is brought about by superior rectus and inferior oblique. Both are supplied by third nerve. And elevation deficit, sometimes it is associated with ptosis. So, think of superior division of third nerve that is involved, and the site of lesion will be posterior orbit or the anterior cavernous sinus, and it can be part of incomplete third nerve palsy also. Now, infraadduction deficit, infraadduction is brought about by inferior rectus and superior oblique muscle. It can be a third nerve palsy or a fourth nerve palsy. So, a few words about fourth nerve palsy. It exits the midbrain dorsally. These are some peculiarities of the fourth nerve. Exit the midbrain dorsally and innervates the contralateral superior oblique muscle. So, it is the most common cause of acute fourth nerve palsy will be trauma. And why it is prone to trauma? It is because of the long course. It is present near the free edge of the tentorian cerebelli, and also trauma can occur the trochlea itself. So, if our diplopia is not localizing in any of these areas, then we can think of other causes like giant cell arteritis, head and neck carcinoma sometimes can have a perineural spread, variants of Guillain-Barré syndrome, and even myasthenia gravis. So, step-by-step approach is the key for diagnosis. Thank you all for your patience here.
Thank you, Dr. Rekha, for a very beautiful presentation explaining all the anatomy and the localization of all lesions in nutshell. Now I invite Professor Dr. Rajini Madam for her talk on acute concomitant esotropia. She is head of the Department of Ophthalmology Department, Government Medical College, Thrissur, and she is one of the senior most professor in our medical education department. Over to you, madam.
A very good morning to all. At the outset, let me thank the KSOS Scientific Committee Chairman and Dr. Rekha for giving me this opportunity. As you all know, during this COVID period, we come across a group of patients who presented with diplopia, with normal ocular movements, and I am going to talk to you about that. So the earliest anecdotal reference is credited to Berrien and Miller, and It is a concomitant, non-accommodative esotropia with acute onset, presenting with diplopia. And there is a very good potential for normal binocular single vision, and surgical outcome also is very good, and there is no tendency for spontaneous resolution. There are subtypes are like this. There is a swan type, occurs after a period of interrupted binocularity, and Franchetti type, where the patient has got a minimal hypermetropia and large angle, often associated with psychological and physical stress, and Belchowski's type, seen in myopes. And this is the commonest type which we come across in COVID time, because every other child was forced to use online classes and mobiles. So it's associated with excess near work and convergent spasm. And less common varieties are the refractive accommodative type, which is controlled with refractive correction alone. And next is the intracranial pathology, which you have to keep in mind in every case. So evaluation should start from the history and the anterior segment and assessment of binocular single vision. A photographic evidence of previously aligned eyes will give you a very good clue. So if you have the history of acute onset of concomitant ESO deviation with presenting with diplopia, older children, full extraocular motility, and large angle squint with photographic evidence of previously aligned eye, make a diagnosis of acute acquired concomitant esotropia. So influence of near work is well documented. Probably the convergence force was significantly greater than the divergence force. And you have to differentiate it from the sixth cranial nerve, cyclic esotropia, divergence insufficiency, refractive esotropia, spasm of near reflex, and myasthenia. All patients should have imaging done, because 6% risk of an underlying neurological disease, especially intracranial tumors, mainly of the cerebellum, brainstem, pituitary, corpus callosum also was reported. Or you should look for evidence of hydrocephalus in imaging, and thalamic and pontine glioma. And if the patient is in the older onset and recurrence of acute concomitant esotropia, you think of intracranial cause. So you treat, there is no optimized protocol established till now to treat this condition. Your spectacle correction, if there is an accommodative component, or base out prisms to maintain binocularity till the deviation stabilizes. Botox, yes, it's a viable option to maintain binocularity during the waiting period to offset troublesome diplopia. And surgery is indicated after waiting period of 3 to 4 months of spontaneous recovery. And concern is the possible development of suppression. You have to manage these patients with prisms, Botox, and finally surgery. Prisms are feasible only in small deviations, and till the deviation stabilizes, you think of giving prisms. Botulinum toxin, in our setup, the cost is the main problem. A 100 unit vial, which is showed to you by Dr. Amrita, that costs around 23,000 rupees. So only if you have a group of patients to be injected, that is a viable option, and the dose is calculated depending on the amount of deviation. And ptosis is the commonest problem. There are so many reports in the literature which showed the efficacy of botulinum as good as the surgical outcome. And I'm sharing 5 cases in our experience. This is one case, a 12-year-old boy, presented with 1 week duration of binocular diplopia. He had a large angle, extraocular movements were normal, stereopsis was gross, vision was normal, imaging was normal, fundus examination also was normal. In our series, all 5 patients had similar findings of large angle, normal extraocular movements, normal vision, normal fundus, and normal imaging. And he was treated with botulinum toxin last week. The results we are just awaiting, but he shows minimal doses now. The surgical correction is depending on the amount of deviation, unilateral or bilateral, symmetric recession of medial rectus. All our patients underwent bimedial recession. I'll show you the results. This is a patient who is a 15-year-old boy, 4 weeks duration of acute onset of binocular diplopia. 60% diopter esotropia was there. As I already told you, the extraocular movements were normal. There was no suppression. Stereopsis was normal. Vision and fundus and imaging was normal. This is the pre-op and post-op picture of that patient. This is another patient we operated. 10-year-old boy, 1 week duration of binocular diplopia. We had the similar findings of normal ocular movements, and fundus and vision and imaging was also done in all patients. This is the pre-op and post-op picture of this patient. This is another patient, little older patient, and he had a 45% diopter esotropia. We had all normal extraocular movements, vision, fundus and imaging. This is the pre-op picture and the post-op picture. And this is the youngest of the lot who presented with a binocular diplopia. The extraocular movements were normal. It was a concomitant one. Fundus, vision and imaging were normal. This is the pre-op and post-op picture of this patient. So, in acute acquired concomitant esotropia presents with sudden onset of diplopia in older children usually who had previously aligned eyes, and excessive near work and stress plays a major role, and non-accommodative concomitant variety, and the ocular movements are always full, and all patients should have an imaging done and wait for at least 4 months before surgical intervention, and good surgical outcome in our experience. Thank you so much for your patient listening.
Thank you, madam, for that wonderful talk with many practical tips. Any questions from the audience?
I have a question to Dr. Amrita regarding Botox. How often have you done Botox in a repeated dose or repeated manner? Botox injection, can you repeat it after 3-4 months? If it again recurs, will you repeat Botox or not?
Yes, madam. Usually, most of the cases with a proper injection, usually it will resolve with first dose itself, because most of the cases usually is what we have given is in adults, mostly it is the cranial nerve palsies, which by the time the botulinum toxin effect weans off, usually patient will have the nerve would have developed by then. So usually the effect remains constant. And again, as ma'am told, ACE actually all cases responds very well to botulinum toxin. Usually most of the time there is no recurrences, but few of the cases we did have recurrences. So few cases when the patients are not really towards surgery, we gave them the option of repeating the botulinum toxin, but it's a very rare occasion. Usually we opt for a surgery. Usually once botulinum toxin fails, suppose if we think if it is because of a wrong procedure, we might think of re-injecting. Otherwise, mostly surgery is the option.
So there is no harm in re-injecting?
There is no harm in re-injecting.
How frequently you come across doses, ma'am?
Ptosis, ma'am.
Yeah.
Ptosis is quite often, actually, maybe around 50% of the cases.
50.
Yeah. It depends on the technique. Each surgeon has a different technique. When given subconjunctivally without much of extravasation, it is not seen. Any beginners who give in an open technique, there is more chances, so you see more often ptosis. But usually it is there for 1 or 2 weeks, usually it spontaneously resolves.
Regarding the subtypes now of ACE, so if you're planning surgery, is there any difference in the management regarding the subtypes? That is bilateral MR R by R?
So most of the time, depending on the subtypes, we decide first on refractive correction, then wait for the angle of deviation to become constant, because most of these ACE cases usually will have intermittent deviations or variable angle of deviation during the initial presentation. Over time it becomes constant. That is when you can decide on surgery. So ideal surgery, as ma'am told, is bimedial recession, so which works well only when the angle is very large, like more than 60 prisms or so. We decide on splitting on either eye. So we do R&R in one eye and plan for either at the same sitting, plan for the medial rectus of the other eye along with the recess resect in one eye and medial rectus of the other eye, or we do one surgery and give a gap of 3 months and do the other eye surgery. So basically it depends on the amount of deviation. Ma'am, you want to add something about that?
In our experience, we waited for 4 months, minimum 4 months, maximum 6 months. When the angle, the degree of squint may become stabilized. We manage them in between with prisms to relieve, to give comfort to the patient. And all patients we did bimedial by dividing in both eyes, and they gave us very good results.
So if there are no other questions, we'll wind up the session. I request Dr. Rajini Madam to present the memento and certificate to Dr. Amrita.